Yes, he's doing a research thing or something. Yeah.
Okay, absolutely.
Mm-hmm.
All right. Good morning, everybody. Welcome to the Department of Medicine Grand Rounds. The CME code for today is 31625. I'd love to introduce our speaker or reintroduce our speaker. It's been a few years since he last spoke to us here at Robert Wood Johnson. Dr. Lenny Lopez is a professor of medicine and the chief of hospital medicine at UCSF San Francisco VA Medical Center. He currently serves as the co-editor-in-chief of the Journal of General Internal Medicine. Dr. Lopez is active in health services research on healthcare disparities and the social determinants of health of chronic diseases that particularly impact older adults, such as cardiovascular disease. He's also focused on cultural factors that are unique to Latinx populations and has published on the intersection of acculturation, literacy, language, and communication barriers, education status, and the experience of discrimination in everyday life among Latinos in the United States. He's been inducted as a fellow of the American Heart Association and as a senior fellow of the Society of Hospital Medicine. Dr. Lopez has served on several equity-focused national healthcare policy advising committees for the National Academies of Medicine, the Centers for Medicare and Medicaid Services, and the Joint Commission. Dr. Lopez, thank you so much again for joining us.
Thank you, David. Great introduction. Uh, and welcome, a warm welcome to everyone from the dark hours of the pre-dawn morning here in San Francisco. So the sun has yet to rise, but after our talk, it'll be up, I think. Let's see. Share. Okay. I have no conflicts of interest. This is literally our view from the VA Medical Center at Land's End, which is the tip of the San Francisco Peninsula. Um, and I always like to start when I get to talk to all of you that a little over 50 years ago, I was born at St. Peter's University Hospital. So a little bit of a homecoming for me to be able to talk to all of you and share some of the work that I've been doing in the last few decades. And basically, this is our agenda for the next 50 minutes to 60 minutes. I'll start off basically in three blocks. We're going to talk about the latest from 2024 in terms of demographic characteristics of Latino. We'll talk Latinos, and we'll talk about uh, the concept of the exposome, and we'll talk about healthcare disparities and cardiovascular disease. And then we'll talk about how did we get to the state of these disparities and where we're going in terms of eliminating those. And we'll talk about the social determinants of health and what undergirds the social determinants of health, or sometimes called health-related social needs, are the political determinants of health and what we can do about it. I always like this slide because I want everyone to remember that because of the complex history of Latin America, Latinos, both in Latin America and in the US, there's no phenotype, physical phenotype that can say who's Latino and who's not. So it's very important that we get past this idea that there's a certain type of phenotype because we have all groups, racial and ethnic groups represented in Latin America. And of course, because of the geographic heterogeneity, depending how you count, whether you count via the term Hispanic or the term Latinx or Latine, you have between 20 and 34 countries that are part of this sending ground of immigrants to the United States. And just very briefly, and I'll show you the 2024 data, but there are between 55 and 65 million Hispanics, and I'll use the term Hispanic and Latino interchangeably in the US. And by 2060, which is not too far away, 1 in 3 Americans will be of Hispanic origin. However, even in 2025, we still have some limitations on the national health data that we can use to monitor the health and healthcare of Latinos. So actually, in 2024, the latest data from the Pew Research Center, we were actually at 68 million in the United States. Of the Hispanic population. But one of the things that's very important to realize is that most of the Hispanic population is US born. The part here that is foreign born stays pretty constant throughout the last 25 years. So that's a very important caveat that most are not immigrants. And most Latinos are US citizens. This is data from 2024, and you can see that the bulk of almost 50 million of the 60 plus million are US born. Only a small percentage are immigrants, and of those, 9 million are US citizens, and 14 million are not US citizens and have varying degrees of documentation. Another thing that's important to realize is that the educational attainment of Hispanics is quite diverse, but it mirrors very closely to the if you take all Americans, non-Latinos. And so you can see that if you look at this part bar here where there's a some college, it looks very similar to the 28%. So all Hispanics about 25, US born Hispanics 32%, and 17% for foreign born Hispanics. And then the college actually having a bachelor's degree is not too far off. It's about 20 or 25% compared to 35%. So the foreign born Hispanics are more likely to have less than the high school education, but overall, as a population, there is some college education in the group. Because most are US born, you can see the English proficiency of Hispanics is very high. The US born population, 91%, this is from 2021, are English proficient. And the ones that are least likely are foreign born, which would make sense. And the Hispanic population is heterogeneously located throughout the United States. So mostly in the Southwest, the two largest states that, in terms of the Latino population, is the state of California is the number one, and Texas is number two. On this slide, it looks like they're the same, but this data is from 2018. The latest data from 2024 is California is one, Texas is two, and then Florida, and then the Northeast where you guys are located, are the big concentrations of Latinos. And then the third largest area is the state of Illinois. So one of the things that's interesting is that there is no national data until the 1982-1984 National Hispanic Health and Nutrition Examination Survey, which is a form of the early NHANES, the National Health and Nutrition Examination Surveys that are still ongoing. But they did this 2-year sample of 16,000 participants from infant ages to 74 years old. And at the time, it represented 76% of the Hispanic population. And they were only sampling 3 of the Latino subgroups. And when I refer to subgroup, I'm speaking of country of origin. And so the largest group by country of origin are Mexicans, followed by Puerto Ricans, which were primarily in the New York City metropolitan area, the tri-state area, and then Cubans from Dade County, Florida. And the first peer-reviewed papers were not published until the early 1990s. So really, there was no real national data on the health of Hispanics until the early 90s, which is only 30 years ago. And just one caveat, a small historic detail, the term Hispanic first showed up in the 1980 census. Prior to that, the term was not universally used. That's a whole nother historic footnote. And about this time, there was the famous Heckler report in 1985 that caused quite a stir. And Heckler refers to Margaret Heckler, who was the Secretary of Health and Human Services during this time period. And in 1986, because of this report, was the creation of the Health and Human Services Offices of Minority Health was created. And from this, much later on, only about 15 years ago, the National Institutes of Health created its own institute focused on minority health called NIMHD, the National Institutes of Minority Health and Disparities. Um, but this report was groundbreaking because this is the first report that showed national data on health disparities and has this very famous finding that health disparities accounted for 60,000 excess deaths each year, and that the six causes of death accounted, and that only six causes of death accounted for more than 80% of mortality among blacks and other minorities. And you can imagine that cardiovascular disease and cancer were the top two. So from 1985, there was the beginnings of health services research and epidemiology in this area. And the first landmark study was the now famous Institutes of Medicine, now called the National Academies of Medicine, 2003 report, which basically, if you've ever seen it printed, is a very large tome of hundreds of pages of the accumulated research up to that point showing healthcare disparities based on race and ethnicity. This was then followed just recently in 2023 by a follow-up study called Ending Unequal Treatment. And this basically covers the last 20 years of research in terms of health and healthcare disparities and has a very strong focus on interventions and next steps. So it reads quite differently than the prior 20-year earlier study from 2003. And if you look at this, I always tell people that the true measure of we have so many quality measures and process measures and outcomes, but really life expectancy, mortality is the ultimate measure of disparities. And what you can see is that this is the latest data from the CDC. There hasn't been any updates. Is that in terms of longevity, non-Hispanic Asian females and Hispanic females are at the top of the order, reaching a life expectancy at birth into the low 80s, while Hispanic males are about 75 years of age, and the lowest life expectancy is found among American Indian and Alaskan Natives and Black males, which have the 67.8 years of life at birth. And most recently, this paper was published in 2023 in JAMA, looking at the economic burden of what racial, ethnic, and educational health inequities in the United States cost. Brilliant study. And just to highlight it, it's in the area that's red, but what you can see is that the total cost of health inequities for non-white population was estimated at $421 billion, quite a bit. And this was based on estimates looking at excess medical care costs, loss of labor market productivity, and excess premature deaths. And then the economic burden attributed to education-related health inequities for the nation, as I showed earlier, although Latinos have and African Americans and other racial ethnic groups have quite a bit of college or some college, you can see that the cost is almost $1 trillion. It's estimated at $940 billion is the cost of low education and its contribution to health and healthcare disparities. And there are many pathways for this. Primarily, if you think about in this country, we've set up our medical insurance system based on education and employment. And so your employment is highly tied to your education level, and your access to insurance and the quality of your insurance is tied to that employment. So we'll talk about insurance in a little bit, but these are all highly correlated features. So I wanted to take a few minutes to go through the features of how Latinos are doing currently in cardiovascular disease risk factor and prevalence and control. And I will walk you through these, but the overall take-home message is that we're not doing very well in this area. As I noted earlier, back in the 1983 study from the Hispanic National Health and N. Haynes, H. N. Haynes, Hispanic National Nutrition Examination Survey, the major causes of death for Latino males and females in 2022 has not changed. It's the same three top etiologies, number one being cardiovascular disease, cancer, and accidents. So the data looks very similar uh, over 40 years later. Age-adjusted death rates for stroke, again, very interesting situation. At the highest rates are among non-Hispanic blacks, but you can see Hispanics look very similar to non-Hispanic whites. And when you disaggregate, we won't be able to talk about this today, but when you disaggregate Hispanics by country of origin, the highest rates of stroke are found among Mexican and Mexican Americans. And then within, by gender, it's women who have higher rates of stroke. And by type of stroke, it's hemorrhagic strokes, not embolic strokes. So there's a lot of, within each of these bars, we could spend the rest of the hour talking about the details that we have now been able to sort out through large cohorts. The presence of end-stage kidney disease is also interesting. The highest rates, again, among non-Hispanic blacks. But if you look at Hispanic rates and Native American rates across from 2001 to 2021, the last 20 years, they look very similar. So quite high compared to whites and Asians. So high cardiovascular disease death and prevalence of end-stage kidney disease and strokes. And when we look at the risk factors for these outcomes, we can see that the prevalence trends for hypertension, again, the highest rates for hypertension are among the African American population, but Mexican American males are very similar to white males and also not far behind with African Americans, black males and females. The lowest rates being with Mexican American females. And this is data from the last 20 years. Similarly, in NHANES, you can really do research on awareness, treatment, and control of high blood pressure. And I will say overall, we're doing terrible in control of hypertension across all groups. You can see that the rates, the highest rates are among Asian females at almost 30% of control, but everyone else is anywhere from 15% to 25%. But there is a more awareness amongst all the groups, the lowest being among Hispanic males. But the next steps, which are access-related steps, having insurance, having a doctor, and having a regular site of care, this is where all the numbers start dropping in terms of treatment and control. Again, the etiology of this is pretty obvious, and that is the lack of insurance and regular access to care, medical care, for minority groups. Age-adjusted prevalence of diagnosed diabetes. You can see that Hispanics have high rates of diabetes due to high rates of overweight and obesity. And the lowest rates are with non-Hispanic male and female whites. Age-adjusted prevalence of diagnosed diabetes. If you look now here by education level, you can really see the impact across all groups. Your education, having less than a high school education predicts, and is associated with higher prevalence of diagnosed diabetes. And your more than high school is something that is more protective in terms of diagnosed diabetes. And we can talk about the many reasons behind that. So these are data that are just titled Hispanic or Latino, and that's what you can get primarily through NHANES. But as I was mentioning earlier, the most important thing is that there's an enormous amount of heterogeneity of the prevalence of these risk factors by countries of origin for Latinos. So this is my funny Rubik's Cube. I think it's made a comeback, but it's as a child of the 1980s, we spent a lot of time playing with these toys. But the most work that's been done is very recent in terms of disaggregation of data. And this is an NIH-funded, basically, I call it the Framingham Heart Study for Latinos. And it's called the Study of Latinos, the Hispanic Health and Community Survey. And that's because No one can ever agree on Latino or Hispanic as the term to use, but it is the largest cohort with 16,000 Latinos, and it started in 2008. And the recruitment of these 4,000 participants per site were focused on the areas that had the highest concentration of Latinos. In the Southwest, they chose San Diego. In the Midwest, Chicago, and then on the East Coast, New York City, and Miami. And this mirrors very much the Hispanic Haynes study from the 1980s in terms of the concentration of where Latinos were located. This was the big paper that was published in JAMA in 2012. But just by just glancing at it, I'm just giving you examples. You can see that there's a lot of variation in these two risk factors, hypercholesterolemia and obesity, based on country of origins. And you can see that some of the highest rates, I'll just pick obesity, are found amongst Puerto Ricans here. And then you can see that the rates here for women are over 50%. And then if you look at women, women are heavier than men in this wave of the soul study. These things change a little bit in the subsequent waves that have been done in the soul cohort. But you can see the rates amongst women are also very high. They're all across the board in the 40s range, except for South American um, um, folks who come from that part of the world. Men are slightly behind, but not too far behind. And similarly, the patterns are, again, Central Americans have very high hypercholesterolemia, the men, likewise Mexicans and Cuban men, and all in general have in this 50% range high cholesterol. So these are all concerning risk factor prevalences that you would not want to see for the round of healthcare that we're going to need in this generation and the following subsequent generations. Hypertension, if you can see the variation quite a bit, the highest levels are amongst Dominican participants in the cohort, then followed by Puerto Ricans, and then everyone else is pretty much in this 20 to 25% range. Again, the lowest being among South Americans. And we don't have time to get into all of this, but the South American migrants are highly educated, which we saw was associated with having lower prevalence of cardiovascular disease risk factors. Similarly, with diabetes, very high rates across the board. Most groups, except for South Americans, are in the 15 to 20% range. Again, when the denominators are large, you can imagine how many people are affected by this. And then the new way of describing the risk factor scores are through the American Heart Association Life's Essential Eight, which include the traditional Framingham risk factors plus physical activity, diet, and sleep. And just looking at this, you can see that 1 in 5 Latino adults has high cardiovascular health, which is the green. In other words, that they have less prevalence of the risk factors. And so Cubans have the least, and the Puerto Ricans have the least folks who are in good cardiovascular health. The majority of the people are in the middle, and then some groups, again, the Cubans and the Puerto Ricans, have very low cardiovascular health. This is the red. So there's the prevalence here, you can see, varies quite a bit by country of origin. And this, we won't go through all of it, but again, a gestalt looking at it, these are the Life's Essential Eight scores, but by we're just picking Mexican and Puerto Rican side by side, and you can see there's quite a bit of variation, but they cluster sort of in this moderate range, just like we saw in the yellow range, but by demographic characteristics, gender, education, income level, and how many years you've been in the United States. And you can see that having greater than a high school education brings your numbers up compared to those who have less than a high school education amongst both Mexican and Puerto Ricans, just picking one. Similarly, that's correlated with income. Very similar. The higher your income, the more likely you are to be in the green in terms of your life essential eight scores. So this is the latest data that's available in terms of disaggregation of Latino health. There's one more study that you should be aware of that started back in 2003, and this is the Agency for Healthcare Research and Quality, ARC, its National Healthcare Quality and Disparities Report. The latest is 2023, so hopefully the 2024 will come out once we get out of the government shutdown. But this is available online and it's free, and you can go and see all the data by disease, chronic diseases, and by demographics of all sorts. And it includes not just disease process measures and outcomes, but includes measures that you can then group together by race ethnicity. And this is another Gestalt slide where this is between 2019 and 2021, looking at the number and percentage of quality measures at baseline for which disparities related to race ethnicity were improving, which would mean the blue. Everything has remained the same over this time period up to 2021 and worse. So these numbers represent the number of quality measures. And you can see that just looking at everything, we're between the same or worse across all groups. The highest lack of progress is among African Americans and Hispanics. And this is again very similar. This is again access measures in terms of having access to healthcare. You can see that the numbers are really bad for Hispanics, and then followed by Alaska, American Indian, Alaska Natives, and Blacks. Again, the access issues continue to be very poor and getting worse. So how did we get to this? This is what this wonderful maze is all about. So I want to just pivot here in the next 10 to 15 minutes, talking about the social determinants of health. And I'd like to bring this point about this famous gentleman we all learned about in medical school, Virchow, Rudolf Ludwig Karl Virchow, and he was a German pathologist, one of the fathers of pathology and infectious diseases. And we learned about him through Virchow's triad, and he has many, many discoveries, including leukemia and other disease pathologies. But less well known is that he really was a proponent of social medicine, is what he called it. And he believed that, and this is two quotes from his writings, that medicine is a social science and politics is nothing else than medicine on a large scale. So this is the time period that epidemiology and public health was in its early infancy, but he was a big proponent and wrote a lot about this, including had a newspaper that he published, self-published, to really get the word out that social science was the explanation for the health ills of society. And he did a well-known study of a typhoid epidemic, showing that the reason why these individuals were in this state of an epidemic of this infectious disease were due to the social conditions in which they lived and had nothing to do with their character or other theories about disease at the time. So I like to call this the social phenotype. We've been hinting at it by talking about Latinos and heterogeneity and countries of origin and socioeconomic factors. But really, all of these factors, as on the left side here, really come together to create a social phenotype for each one of us. And they all work differently and have different impacts on health and our ability to access and have good health care. Back in 2015, gosh, almost 10 years, we're a little over 10 years ago, there was a new initiative that the NIH really was pushing forward, and Obama was very much behind it, giving increased funding to the NIH, and it was the big precision medicine initiative. And I know everyone has heard about precision medicine because we talk about it nonstop. But the term that I wanted to make sure we all knew about, which was first coined in 2005, was the notion of the exposome. And really, the idea is quite similar to what the social determinants of health is that for each individual, there are external environmental factors, which we talk about in the world of the social determinants of health. And then a general, we're all inside climate and green space and urban environments and traffic. And so all of these factors come together with our genetics. And this is proteomics and metabolomics and everything else. And all of this works together to create health risk and impact. So across the life course, This is how the social determinants really now are considered part of our exposome. So what I always say is that social cultural tailoring is precision medicine, and when we get to a small portion, I have another whole talk about in what we know about successful interventions in reducing healthcare disparities in amongst Latinos. Precision medicine is part of the realm of this exposome. Addressing those factors help improve health and healthcare. When in the early days, now over 10 years ago, when the social and behavioral determinants were really in the forefront, and it was the beginning and the push to get electronic health records everywhere in healthcare, the institutes of medicine at the time, national academies, uh, they put together a group of experts in this area to decide what of all of these factors are related to health and related to the social needs that we could improve on by keeping track and then trying to intervene on them. And they decided that the easiest way to do this was to implement something that was simple in the EHR. And we're still in this world of collecting, whether to collect and how to collect social determinants in the EHR. But they basically had 25 questions that takes less than 10 minutes to fill out. Um, and it can be done in many different ways through the portal or paper forms. But basically, it's all the things that we know that are socially rooted things that impact health and healthcare. Everything from your zip code, excuse me, all the way to factors such as financial resources, intimate partner violence, your degree and levels of physical activity, social isolation, which Vivek Murthy, our prior Surgeon General, really pushed. But these are the factors that are considered to be important to address in the health and healthcare setting. And this is with the classic onion description of how we, back in the exposome, we at the center are surrounded by our own individual lifestyle factors, but we're embedded in social and community networks and living and working conditions, which is everything from housing to your work environment, to water sanitation, to your access to food. And all of that is rooted in the historic socioeconomic decisions that we have made over the last 2+ centuries on how we want to live and see all of us live in particular environments. Underlining this in the last 5 years has been a big discussion that racism is part of the reason why a lot of these factors are the way they are and impact differentially across race, ethnicity, socioeconomic status, gender, and many of the other of these intersectional identities. I was lucky enough. This just was published this a few weeks ago, actually 2 weeks ago. We worked on this National Academies of Medicine report for the last 2 years, and it's a giant report which starts with all the factors associated with our current status of where we are as a nation, and the focus was on the systems that impact population health. And this is available and published by the American Public Health Association and sponsored by the National Academies of Medicine. And it goes through each racial and ethnic group, its history, and its current status across education, employment, housing, food access, etc. And it includes a whole chapter on white race as well. So all groups are represented here. And it's an interesting study. This could be a whole conversation as to how we got here, is the focus of this study. But I just want to highlight something that the social determinants of health, they really account for a large proportion of the outcomes that we see. And across multiple studies, you can see that almost 50% to 60% of health and healthcare outcomes are basically due to socioeconomics. You can see that healthcare is the next biggest slice of the pie. That's the issues around access and having a regular place of care. And then you find behavior, environment, and genetics. But socioeconomic status is the number one driver. And a great study that came out in 2023 showed that the number of unfavorable social determinants of health, the more of them that you are exposed to in your exposome, also is associated with your cumulative mortality. So having greater than 6 factors in this study, for example, gave you the highest rates of mortality compared to someone who only had exposure to 1 or 2 factors. So impressive study showing that the social determinants of health are directly associated with your mortality rate. And then a study that we did a few years ago, we looked at the social determinant of health burden with hospitalization, and we saw a very similar pattern. As you increase the number of social determinant of health factors that you're exposed to, there's an increase, nice monotonic increase in your unadjusted and adjusted rates of hospitalization. Basically, you're sicker if you are exposed to more social determinants of health factors, and I would call them negative social determinants of health factors. Most recently, and I wanted to show this to you, was published this year in JAMA. One of the questions people often have is, what is the benefit that we see in terms of, in this case, we're going to talk about Medicaid, if we address the social determinants of health? And there was this, my colleague and friend, Seth Berkowitz, is the first author and was the lead PI on this grant. But he took advantage of the fact that North Carolina was using a 1115 waiver in its Medicaid program to create a pilot called the Healthy Opportunity Pilots Program. And they were specifically to allow for the payment of non-medical services to address health-related social needs in 3 rural regions of North Carolina, not the whole state. So there's a comparator of intervention versus non-intervention. And there was a interrupted time series evaluation from March 2021 to November 2023. And it was looking at the change in the monthly cost of the folks who were in this pilot program to address these factors versus the ones who were not in the program were ineligible for a variety of reasons. So 13,000 individuals versus almost 74,000 in the non-participating group. And I just wanted to show you this. We don't have to go through it, but what was interesting was that the majority of the investment in money was in food services, the food boxes, fruit and vegetable prescriptions, healthy meals, medically tailored meals. So food was the number one intervention for the majority of the participants. And the next was housing, navigation, utility setup, inspections, all of the things that we don't think very much about for those of us who are privileged enough to have enough money. But food and housing, followed by transportation, were the major interventions that were paid for through the Medicaid program. And then there were more complicated things, but not as the frequency was not as high, or things such as legal issues and enhanced case management, parenting curriculums, interpersonal violence surveys. But those were not the bulk of the services provided. And this table looks busy, but it's simple. And I will just show you the here on the left are the change in cost, monthly cost. These are adjusted, fully adjusted models for demographic characteristics for those who were in the pilot, the Healthy Opportunities pilot, and those who were not. And that you see in the first column shows you that everyone in the first month of being in the program had an increase in their cost, their monthly cost, because they're receiving services. But over a 12-month period, everyone in this Healthy Opportunities pilot had a very large decrease in their monthly charge expense to the Medicaid program. And although you saw something similar, sort of a trend towards lower costs in the non-Healthy Opportunities pilot, the change was much smaller. So this study is one of many that have been coming out showing that we don't want to be penny wise and pound foolish, as the saying goes, that you do need to invest money into addressing these factors that negatively impact health. But over time, you will actually do better in terms of the cost. The costs do come down over time when you address, in this case, primarily food and housing. So a very interesting study, not definitive, but at least in this very interesting natural experiment, it was a very interesting finding to think about. And this is a whole another talk, and I think I gave a version of this last time. All disparity solutions are local, and so this list that you have here are all of the things we know that if you address them, you eliminate disparities. So if you have access to health care, if you have good quality insurance, and if you have a place to get your health care that's consistent, and you have all of the tailoring that you need, language, culture, I am a true believer that patient navigation, we don't need to do more studies because we have 25 years of positive studies showing everyone benefits, even if you don't have social determinant of health issues from patient navigation. Most of us cannot remember to take a pill twice a day, but having a coach would help a lot. And people who have the money to pay have individualized coaches at their gyms and all this other kinds of places on your phone. There's apps, all sorts of things. So really thinking about embedding these in healthcare systems. For example, chronic disease management, we have studies all the way going back to the 90s that chronic disease management is the way to go, and most places have versions of this in certain fashion. But we won't get into all of this. But we do know what to do. It's just an issue of investment and restructuring our healthcare delivery. So this is our final section, and that is that the social determinants of health are the way they are, which is what we talked about in that new publication from the National Academies of Medicine, because of the political determinants of health. These are the decisions that have been made over the decades as to how we would structure our health care system and in the places where people live. There is a lot of stuff here that makes sense, that political determinants of health are government and policy and all of these kinds of superstructural issues. But I want to focus on two things, and is that in this model with all its circles and squares and arrows, it's voting and advocacy are the main levers that most people have to impact these political determinants of health. So as physicians, this is our way. Not only do we do one-on-one care of patients, but in terms of changing the structures that we are currently embedded in, it's through voting and advocacy of the things that we think are and know to be, based on research, important for addressing the negative factors that impact people's health. I just want to talk about political opinions, and political opinions matter. They actually have impact on mortality. This was a fun study that was put together using the CDC Wonder data set, looking at and published in the New York Times, the greatest scientific journal from all people. But basically, it really shows that the mortality rates of COVID 19 deaths really were different by the vote of the political party you were most affiliated with. So the lowest rates were in places that were primarily Democratic, and the highest rates were amongst folks who were leaning towards the Republican Party and at that time the agenda of non-vaccines. And this is currently published just in September in the New England Journal, by Bob Blendon, looking at how the opinions have impacted health and medical research funding ideas in the general population, based on, and this study was based on all of these data polls, both media, CNN, Gallup, Pew Research Center. And basically, the take-home message is that you can see the split between Republicans and Democrats on the viewpoints of whether there was confidence in higher education, whether the maintenance of federal funding for scientific and medical research, whether colleges and universities, whether they should not get federal funding if they don't comply with the president's goals. So all of these things split down the middle, with Republicans and Democrats having very different opinions, but primarily Democrats having a favorable view of federal funding, higher education, and research. The other point I wanted to highlight is that over time, although we are investing and studying, I've showed you studies after studies about disparities, we have a chronic underinvestment in funding. And I'm just going to show you one example, and that is the NIH. And I just want you to focus on that one bar because this looks like a lot of numbers. But this is a table that was compiled by a National Academies of Medicine study looking at the direct costs for health equity related projects versus all other topic projects between 2004 and 2023. And the column at the right side is the most important because it allows you to see the percentage of the budget at these institutes where that was focused on health equity. And it was primarily at the National Institutes of Minority Health Disparities. That's where they were the ones who were primarily funding equity research. The next closest one was the NCATS, which is the National Center for Advancing Translational Science, because this is the implementation arm of disparities research. But other than that, you can see it's a trickle of money that's going towards funding and researching disparities in the implementation science for disparities. So I want to just talk about come back to access, and this is really a politically determined issue because we have set up our healthcare system in a way that has made it difficult for many people to have access to insurance, and this goes across race and ethnicity. What I'd like about this issue brief published by the Secretary of Planning and Evaluation at HHSS is that you can see truly the impact of the ACA, Obamacare, on rates of uninsurance. You can see just looking at all the numbers how there's a downward slope here. But in all of these groups, Latino and American Indian and Alaskan Natives have the highest rates of uninsurance. And between 2010 and 2022, there was a 15% drop in uninsurance, which really represented about 16 million individuals being insured. A very large impact by the ACA across the board. And again, if you look at the type of coverage, remember we talked about most Latinos are U.S. born, and they are employment-based insurance is the primary way of getting insurance. But Medicaid is next, and that's primarily because there are a lot of Latinos work in sectors of the economy that don't provide insurance that's employment-based. So that is the next way that most of them are attaining insurance. Direct purchase in the exchanges is pretty low amongst Latinos. And this lack of consistent insurance leads to, and I just want to highlight, crosses from 2010 to 2022, these pretty high rates of no usual source of care, delayed care due to costs, and this worrying about medical bills and delayed filling of prescriptions. These are all the downward effects of not having consistent insurance. So I want to get to this section, which is this just was published this year at the beginning of 2025, the New England Journal. And basically, it's an interesting study showing what we've known since the 1970s, the RAND insurance research program, and that is that cost sharing always leads to worse outcomes for patients. So they looked at what happens if you lose your subsidized drug coverage and its impact on mortality among Medicare beneficiaries. So there are about 14 million Medicare beneficiaries that receive low-income subsidies for Medicare Part D, which is the pharmacy benefit. And losing the subsidized, the LIS, the low-income subsidy, really impedes medication access and affects mortality. And they looked at the data from 2015 to 2023, looking at dual eligible Medicare and Medicaid beneficiaries who automatically receive the low-income subsidy. And they looked at the annual rates of Medicaid and low-income subsidy loss. And what they did was they looked at beneficiaries who disenrolled from Medicaid from January to June and who kept the low-income subsidy through that year's December. So they got another 6 to 11 additional months of coverage. That was about almost 1 million people, 970,000. And then they looked at those who disenrolled in the second half of the year who kept their low-income subsidy for another entire year, because the way the rules work and they got an additional 12 to 17 months of coverage. And what you can see here is that on the left-hand side, on the y-axis, you have the percentage surviving over time, and basically the curves split, and they show that basically losing your low income subsidy because you were disenrolled from Medicaid early on in the year, over a 2-year period, you have an increased mortality, which is nicely illustrated here. Again, this is the cumulative difference. By 17 months, this represents 3 deaths per every 1,000 Medicare and Medicaid dual eligible individuals. And these were primarily folks who had a lot of chronic diseases, who were dependent on medication for their CHF, their COPD, and their HIV diagnoses. So the sicker you are, losing the low income subsidy really impacts your mortality. I want to briefly talk about immigration as we wrap up. And this is a complicated issue that's in the news all the time. And I like this little Venn diagram because it shows, remember that most Latinos are US born. There are immigrants, and within that immigrant group, there are undocumented immigrants. These are documented immigrants. Undocumented immigrants, all of these are a Venn diagram because there are people and families and social networks where there are mixed status individuals, as well as what they call them. And those are individuals who basically families or other social groupings where there are documented and undocumented individuals and US citizens all together. What I want to highlight is that these experiences of immigrants are state level. There's federal laws, there's state laws, and local laws. But what really matters in terms of your ability to live and having the ability to pay your bills and send your kids to school or you go to school is all based at the state level. So your health and welfare benefits, your education benefits, labor laws, having a driver's license and ID, and the degree that there is immigration enforcement all impacts the quality of life. I'm going to skip this because this is a better picture here. And that is, you can see that the inclusive and exclusive policies really vary by states. So the most inclusive states for immigrants are here in Washington, Oregon, California, and the Northeast. And then we have a big section here in red that have a lot of state laws that are exclusive, that make it difficult for immigrants to live. This just shows you, this is a index that shows you the immigration policy climate. And this is a research index that looks at state laws. In this case, they're looking at over 700 state policies. But blue in this situation are environments that have positive and inclusive immigration policies for the livelihood of immigrants, and that the most welcoming is California, and then the least welcoming is the state of Alabama. And you have just a huge spread of how these policies would impact people's lives. I'm going to skip these because we've talked about uninsurance. But one of the things that I want to end with is that it's deadly to be an undocumented immigrant with regards to your health care. And this was a study published in 2022 using data from 1998 to 2014, looking at Latinos age 14 to 44. So this is a young group, and using data from NHIS. And you can see that in these adjusted models, the non-citizens have first a trend to more death over time during this time period. But the major issue is cancer in this young group. After you fully adjust the models, they have a twofold risk of dying compared to US citizens, and that is due to the lack of insurance and access to care. In the final adjusted models, they didn't shake out, but there was a trend to it. But again, cardiometabolic diseases and accidents were much higher causes of death for undocumented immigrants who are relatively young, between the ages of 14 and 44. So again, being in this and having an undocumented status is bad for your health and your life. These are the things we've talked about. We talked about Latino demographics. We talked about the social determinants of health and how these are determined by the political determinants of health. And one of the things I want to say is always for me a great fun thing to highlight, since we all spend so much time being at lectures, is the Ebbinghaus forgetting curve. And within the first day, we lose more than half of everything that we learned or listened to during that day. So I would encourage folks, if you're interested in any of the details, to go back to the recording to review the data so that you can increase your retention of what we covered this morning in 50 minutes. So I always say, let us not leave Latino health to chance for politics, and that physicians, we can make a difference through our advocacy and our expertise in societal power and respect. We can really make a difference in the political determinants of health that really would make an impact for our patients. So I just wanted to make sure we had a few minutes for questions, comments, and discussion. And I was not following the chat or anything like that, but maybe David would help. No, okay. So
No,
people can unmute if they want to.
yes, thank you. Dr. Hussein, I think you had a question or a comment.
Yeah, I did. I just want to thank you so much. I mean, it's an incredible talk, Dr. Lopez. I've been working in this area for a bit of time, and I think your comment about navigation is just right on. I mean, I think that's really the key
Mhm.
to make sure, and I truly believe that every person needs to be navigated. It's not,
Absolutely.
it's not just, oh, okay, they don't speak the language, and I
Right.
think everyone needs to be navigated. One
Right.
question I sort of did have is like, I also run into this issue. Like we have these individuals who are undocumented. They don't
Yes.
have, we can't help. Like, how do you think, like, what is the policy or how do we advocate for that to be something that we address? Like, is there a way?
Yes, I have. I did not get into that because that's a whole nother talk. But I have a talk on undocumented immigration, and you can make a big difference through policy. And a good example of this has been the work of Lilia Cervantes, who's in Denver, Colorado. And she was a hospitalist, a non-researcher, and then had the repeated experience in the county hospital in Denver of having to deal with emergency dialysis because it was the only the only thing paid for those who presented with end-stage renal disease with hyperkalemia and acidosis. And they would get dialyzed and then sent home. And eventually, these patients have very high mortality rates. And because of the data she accumulated and published, she was able to change the policy through creating networks, advocacy networks, and now over 12 to 15 states. And now they've eliminated emergency dialysis and provide standard hemodialysis for undocumented immigrants. So it is possible, but these are long roads. And the quote that I use here from my colleague Marshall Chin, who published this in JJAM, Journal of Internal Medicine, is that what we're really talking about, what you just mentioned, is just human cruelty. I mean, as providers, it's very hard for us to see that kind of suffering. So
No,
thank you for your comment.
no,
Absolutely.
thank you so much, Dr.
Yeah. And we won't even get into cancer care for undocumented immigrants. Another cruel, just terrible situation. But there's a lot of data in this area too. Okay.
Thank you, Dr. Lopez, for great talk, as Dr. Hussein mentioned. You talked about chronic underinvestment in and workforce shortages,
Mm-hmm.
Latino health research. What
Mm-hmm.
can we do? What can medical schools do? What can health systems do? What can departments do to help build pipelines of Latino researchers and clinicians and academicians?
Right. Well, what most of the large academic centers are doing is continuing the work that we have been doing. We may label it now differently, maybe community engagement or other kinds of things, but you've got to continue that because the data shows that the quality of care, the perception of the quality of care, adherence to medications, willingness to come back to physician visits, both in the hospital and outpatient setting, are increased through concordance between providers and their patients. So not only race, ethnicity, but gender as well. So we have to continue if we're going to actually be able to meet our patients where they are. We know the data. And the data is that we need more diversity. I know it's a bad word now, but we need more folks from different backgrounds in medicine, public health, and all the allied health professions. It's the only way to really make a difference over time.
Wonderful. Thank you. We have a question in here.
Oh, yeah.
The question is, what is the condition of the Latino healthcare force in the United States of America? I think you could
So we covered
that many different ways.
Yeah, we cover this in the National Academies of Medicine report that just came out. I encourage you to take a look at it. But basically, it's quite poor. And that is probably because we're not introducing STEM and other health related pathways early on in a lot of people's educational careers in high school and in colleges. It may be too late by then. We should probably be introducing it much earlier. They are not well represented as physicians. As physicians, just like African Americans, we're in the single digits. Even though we are 60 plus million, the number of physicians is tiny. And then very similarly with nursing and other allied health professions, pharmacy, also very low numbers. So we would really need more of these pathways that introduce students early on, middle school and in high school, into the health professions. A really great point. Again, these are generational projects, and why we need to invest on a governmental health policy level, because otherwise, small things here and there, they have impact, but you're not going to get the big changes that you need because of the chronic underinvestment.
Thank you. And I think there's we're past the hour, but Dr. Fisher, I think you had one last question or comment.
I hope my audio is coming through. Is it?
Yes.
Yes, we can hear you. Yes.
One of the things that I have felt very strongly about, and I'm a PGY 56, is that
Congratulations.
Thank you. There should be a social worker consultation on every admission as close to the time of admission as possible. I think it would prevent a huge amount of morbidity and also prevent repeat admissions. What is your opinion of this, Dr. Lopez? And thank you. A beautiful presentation.
We have data on that. We know that is absolutely true. Both in the inpatient and outpatient setting. The outpatient setting, the chronic disease management model is all about social work and nursing and navigation. And in the inpatient, you cannot possibly deal with individuals' entire social needs, network issues without social work. I mean, as physicians, we're not trained. I don't even know half of the resources that are available in the communities. So absolutely. But we have the data. We know that. We
just got to get the people who write the budgets to provide for it.
Exactly. Back to the political determinants of health, and the way we pay social workers and interpreters and all the folks that we actually need to care for our patients is usually under a general, it's not a line item that is paid by the state governments through Medicaid or through Medicare. It's just a service charge. It's a facility charge, and they get a lump sum of money, and the folks who run the health system determine how much they want to spend for social works, interpreters, and all of that. And that's why these departments are usually very underfunded and understaffed because of the payment models. They're not line items. Right, so we're back to the political determinants of health.
Thank you very much, Dr. Lopez, for a wonderful
talk. It was great fun. Thank you.
Great to have you here.
Me. Yes, thank you.
Thank you so much.
Enjoy the rest of your day.
All right, you too, and we'll see everybody next week.
Okay, bye-bye.